Bismillah ar-Rahman ar-Rahim. After formal inauguration, we will proceed to our industrial session. First industrial session is the role of Ibrutinib in CLL. This marvelous journey started in 1993 when first gluten tyrosine kinase gene was recognized, and this was followed by FDA approval of Ibrutinib in relapsed mantle cell lymphoma in November 2013, followed by approval for CLL in February 2014. Today we have with us Professor Nida Anwar, consultant hematologist from National Institute of Blood Diseases, Karachi. Professor Nida will educate us about the role of Ibrutinib in CLL. Over to you, ma'am.
Thank you so much for the kind introduction. So today I'll be speaking about role of ibrutinib in chronic lymphocytic leukemia. Chronic lymphocytic leukemia is usually an indolent lymphoma, having a very indolent presentation. At times, there's only incidental finding on the CBC, which prompts the patient to medical attention. In most of the cases, wait and watch strategy is the only thing that hematologist needs to do, because not every CLL needs treatment. There are certain indications for the treatment depending upon the International CLL Working Group criteria, which warrants the initiation of treatment. This is a very challenging aspect because the patient is anxious. The patient wants to know, if I have a disease, I'm not being treated. So this requires patient education, awareness, and reassurance. Some of the gaps and challenges that we face as physicians in our part of the world is lack of awareness. Lack of awareness of the patients, caregivers, and at times physicians too. Cost. Cost is one of the major hurdle, and especially a lot of treatment in CLL and other hematological malignancies. The treatments are not finite, so cost is a major hurdle. Then one of the gap is the unregistered drugs, the baggage drugs, for which there's questionable efficacy, availability, and a good burden of the malignancies lie in the rural areas. The treatment lies in the big centers, in the big cities, and it becomes very difficult for the patient to timely reach for the treatment. Then there's a scarcity and lack of the consensus national guidelines, no funding, lack of MDTs, and tumor board meetings. So this is the slide taken from British Journal of Hematology guidelines. As I mentioned, not every CLL needs treatment. So if there's an indication of treatment and the patient fulfills the International Working Group criteria of CLL, it's fine. Otherwise, you continue wait and watch approach. And if there is an indication of treatment, screen the patient for TP53 disruption and IGHP mutational status. Again, very important is individualized approach, which has to be patient tailored, keeping in view the patient comorbs, patient preference, and concurrent medication that the patient is taken. At every timeline of the treatment, always consider clinical trials where available and applicable. So according to the British guidelines, chemoimmunotherapy historically still remains the frontline therapy for certain group of patients who have intact TP53, means no disruption, no known comorbs, good performance status, mutated IGHV, and these are the certain group of patients who are potentially younger group suitable for FCR. The other frontline treatment options are venetoclax, obinutuzumab, and if the TP53 is disrupted, is there any IGH mutation status, patient is not suitable for FCR, and this TP53 intact and it's unavailable or so. So the frontline treatment are acalabrutinib plus minus obinutuzumab, venetoclax obinutuzumab, ibrutinib as a single agent, and venetoclax as monotherapy. At all points of time, we have to keep always LOBMT in mind for those group of high-risk patients who have TP53 disrupted, and especially in those cohort of the patient who fail first-line BTKI or BCL2 inhibitors. And we have to start second-line treatment. The choice of second-line agents is once again BTKI inhibitors, acalabrutinib or ibrutinib. venetoclax and rituximab combination, or either venetoclax as a monotherapy. Always consider alternative BTKI if BTKI, one of the BTKI is intolerant or toxicities. Again, consider LOBMT for suitable patients who still fail to do with the second line of treatment or chemoimmunotherapy or BTKI or BCL2 inhibitors, irrespective of TP53 status. The third line treatment or the successive treatment is always influenced by the prior treatment that the patient is having. At the time of the relapse or refractoriness, what is the status of the disease, what are the patient comorbs, what are the patient preference, and the options. In this setting of third line, we have again venetoclax plus minus rituximab if the patient was BCL2 inhibitor naive, or BTKI inhibitor if the patient was BTKI inhibitor naive. Venetoclax retreatment can be offered even if the patient was previously given venetoclax, or you can do alternative BKI if there's intolerance. And another option is idelalisib and rituximab. So according to the NICE guidelines, the NICE approved treatment says venetoclax, obinutuzumab, or acalabrutinib are recommended options as initial therapy in patients who are unsuitable for chemoimmunotherapy irrespective of TP53 status. Bendamustine and chlorambucil-based chemoimmunotherapy are no longer recommended. NICE approved treatment options for fit patients with TP53 disruption include ibrutinib, acalabrutinib, or venetoclax monotherapy for those with contraindication to B-cell receptor inhibitors. The recommendations which are not NICE approved are obinutuzumab as a frontline treatment option for all patients with or without TP53 disruption. Ibrutinib monotherapy is a frontline treatment option for all patients or without TP53, with or without TP53 disruption. So now, how to choose optimal treatment? Again, there's no straightforward answer. It has to be individualized approach, but the important thing is local circumstances. We have lack of national guidelines, so all these guidelines are there to guide us, but the most important aspect is the local circumstances: drug availability, patient preference, availability of the drug, comfort of the centers, their experience, patient-related factors, disease-related factors. High-risk factors are very important that on the baseline, ideally we should stratify and keep those risk factors in mind. Then the treatment-related factors, patient preference, patient past medical history, and the concomitant medication and the drug that the patient is on. So the topic of today's presentation is role of ibrutinib. So these are the various trials that I would like to discuss. Resonate 2, Illuminate trial, Alliance, Captivate, and Glow. So Resonate 2 was the first trial in which ibrutinib was used in the frontline setting. It was a randomized, open-label, phase 3 randomized trial. It enrolled patients more than 65 of years who were treatment naive. It enrolled 269 patients, and it compared ibrutinib 420 milligram once daily until disease progression or unacceptable toxicity with chlorambucil for up to 12 cycles. The primary endpoint was progression-free survival, and the secondary endpoint was overall response rate and overall survival. So basically, the patients with deletion 17p were excluded, and again, their primary endpoint was progression-free survival. Overall survival was a secondary endpoint. The Resonate 2 primary analysis revealed overall survival of 95% with ibrutinib, in comparison to the 84% overall survival with chlorambucil. However, to note, 41% patients in this trial who were chlorambucil treated crossed over to ibrutinib upon disease progression. The drastic difference was seen in the progression-free survival, which was the primary aim, and there was a marked difference. 90% progression-free survival was seen in the ibrutinib arm as compared to the 52% progression-free survival that was found in the chlorambucil arm. Then they followed the patient over 7 years after the initial response assessment. So they found out that ibrutinib was well tolerated in this older population, with 47% of the patients still remaining on the treatment at the end of the trial at this time point. And continued ibrutinib also improved depth of response with complete remission and complete remission with incomplete count recovery, increasing from 11% at the initial assessment over 18 months to 34% after a median follow-up of 7 years. Risk factors, they are very important. As I already mentioned, the risk factors, the high risk factors in the CLL are very imminent to identify because they predict the faster disease progression. 50% of the patient, or even more than 50% of the patients of CLL have unmutated IGHV. 10% of the patients harbor deletion 17p, 25% approximately are the patients who have deletion level 11q. So Resonate 2, unfortunately, didn't tested the patients for IGHV mutation status. But these are the factors that have to keep in mind. Then this is another phase 3 trial which compared Ibrutinib and Rituximab versus the FCR. In total, they enrolled 529 patients. The median age was 58 years. And majority of the patients had very good performance status of ECOG 0 to 1. The patients were, 43% of the patients were advanced stage, having RAI 3 to 4. And this trial also included the patients with high-risk factors like TP53 mutation, deletion 11q, unmutated IGHV in majority of the patients. However, they excluded the patient who had deletion 17p. So the primary endpoint was progression-free survival once again. And this trial found out 89% progression-free survival in the Ibrutinib plus Rituximab arm as compared to the patients who were given FCR, having progression-free survival of 70%. And in the overall survival, which was a secondary endpoint, the cohort of Ibrutinib plus Rituximab had overall survival of 98% as compared to 92%. In overall survival, there was not much marked difference. The difference was seen in progression-free survival. Another trial was Illuminate trial. This trial basically evaluated again treatment-naive patients with CLL and SLL. These were the elderly patients, more than 65 years, or treatment-naive patients, again, who are less than 65, but had at least one of the following comorbidities, like coexisting medical conditions or reduced renal functions or deletion 17p or TP53 disruption. So it was 1-to-1 head randomization. One of the arm received Ibrutinib plus obinutuzumab, and one of the arm received chlorambucil plus obinutuzumab. Their primary endpoint was progression-free survival, and their additional endpoints include progression-free survival in high-risk population and overall response rate. So this was again phase 3 multi-center trial, and they found out, they basically see the high-risk populations with unmutated IGHV, deletion 17p, TP53, and assess the overall response rate. So what they found out was there was superior progression-free survival in Ibrutinib obinutuzumab arm in the frontline CLL as compared to the cohort which were given chlorambucil and obinutuzumab and had progression-free survival of 31% as compared to 79% of progression-free survival seen in Ibrutinib and obinutuzumab arm. Then one of the trial was Alliance trial. This trial enrolled 3 arms of the patient with 1-to-1 randomization. They were all treatment-naive CLL patients, more than 65 years. One arm received Ibrutinib. It was given in standard dose of 420 milligram once daily until disease progression or unacceptable toxicity. One of the arm received bendamustine and Rituximab, and another arm received Ibrutinib plus Rituximab. Their primary endpoint was once again progression-free survival, and secondary endpoint was overall response rate and overall survival. The various patient characteristics were a total of 447 patients were enrolled, 1:1 ratio in all. The median age was 71 years. Majority of the patient had very good ECOG performance status of 0 to 1. And they also included the patients with high-risk characteristics like deletion 17p, deletion 11q, TP53 mutation, and unmethylated Z70 patients. So what they found out was, again, in this trial, there was statistically significant progression-free survival superiority seen with Ibrutinib as compared to bendamustine Rituximab. And the secondary endpoint was overall survival. However, 30 of the patients who were treated initially with bendamustine crossed over to Ibrutinib monotherapy within 1 year after the disease was progressed. There was no statistically significant differences seen in the overall survival. The difference was seen in progression-free survival. And there was notably no additional benefit of adding rituximab to ibrutinib. Another trial was Captivate trial. This was phase 2 trial, which combined venetoclax with ibrutinib in previously untreated CLL. And this trial included patients who were fit, under 65 of years, but had at least one of the high-risk factors like deletion 17p, TP53, mutation deletion 11q, or unmutated IGHV. So after 12 cycles of combined treatment, 88% of the patient had complete response or complete response with incomplete count recovery, and 61% of the patients were MRD negative, leading to this drug with FDA approval. And most common grade 3, the most common toxicity in the cohort was seen grade 3 or 4 neutropenia. Another trial is the GLOW trial. This is the phase 3 trial. And in this trial, the less fit patients of over 65 years old or younger patients with cumulative illness rating scale score of more than 6 or having certain comorbs like creatinine clearance of less than 70 were included, and they were given fixed duration of venetoclax and ibrutinib. What they saw was there was improved progression-free survival in venetoclax and ibrutinib arm, that is 76% at 27 months, compared with chlorambucil and obinutuzumab. And this was consistent across predefined subgroups, including patients with unmutated, like high-risk mutations like unmutated IGHV, high-risk patients, but with known TP53 disruption. This was the cohort which was excluded. So basically, the undetectable bone marrow MRD rates by next generation sequencing was significantly higher in this cohort of the patient, which were given ibrutinib and venetoclax after the end of treatment compared to the chlorambucil obinutuzumab. And the most common grade 3 or 4 adverse events in both arm groups was neutropenia, infections, and diarrhea. And 22.6% of the patients in the trial discontinued the treatment due to toxicity. Then coming, this one of the RESONATE trial, the initially trial that I discussed was RESONATE 2 in the frontline setting. This trial is RESONATE trial initially tested for ibrutinib in relapse or refractory setting of CLL and SLL. This trial basically included 391 patients who were previously treated with CLL or SLL. And in this trial, patients with 17p deletion were also included, and it comprised 127 patients. There was 1-to-1 randomization comparing ibrutinib in the standard dose until disease progression or unacceptable toxicity versus IV ofatumumab for up to 12 doses. Their primary endpoint was progression-free survival, and secondary endpoint was overall response rate and overall survival. So what they saw was there was prolonged progression-free survival in the monotherapy arm of ibrutinib for those patients who were previously treated for CLL, as compared to the patient who were given ofatumumab. So progression-free survival of 88%, which was statistically significant. Reduction in disease progression or death was seen in the ibrutinib arm, that is 88%, versus 65% in ofatumumab arm. And the long-term follow-up analysis that was done over a follow-up of 63 months also found that there were overall superior progression-free survival with ibrutinib as compared to ofatumumab. Again, there are certain treatment gaps. Again, I would like to highlight that we have to address especially the high-risk characteristics like deletion 17p, because up to 10% of the patients who are given the frontline treatment or are the naive patients, they harbor deletion 17p, but the trend increases up to 50% in the patients who are previously treated. So it's a strong genetic predictive factor of poor outcomes that has to be evaluated, because it basically predicts the rapid disease progression and reduced overall survival. So RESONATE again revealed decreased reduction in the risk of progression or death in the ibrutinib with ofatumumab. and superior progression-free survival. Their secondary objective was overall response rate. Again, it was very drastically superior in ibrutinib balm with overall response rate of 43% as compared to the 4% seen in the ofatumumab arm. So with that, I conclude my presentation. Thank you very much for your kind attention. Thank you.